All right, let's dive right into this explainer and absolutely conquer the high-yield clinical vignettes for the Hacek group and zoonotic gram-negative pathogens. If you're prepping for your board exams or just looking to sharpen your clinical microbiology knowledge, you already know these fastidious little bugs love to hide in test questions. So today, we're going to extract the absolute must-know facts from our sources so you can spot these pathogens a mile away. So here's our roadmap for today. We'll start by decoding the HACEK mnemonic, then look at the endocarditis patient, move on to the bite wound patient, and finally wrap up with pediatric and rare pathogens. Let's get to it. Section 1, Decoding the Hacek mnemonic. Let's break down this famous acronym so you've got a rock-solid foundation for these tricky little pathogens. Okay, so these 5 letters represent a really unique family of bacteria. H is for Haemophilus, specifically H. parainfluenzae. A is Aggregatibacter. Now put a huge mental star next to this one because it literally takes the crown as the most common cause of Hacek endocarditis, and it's heavily linked to dental procedures. C is Cardiobacterium. E stands for Eikenella corrodens, which is your classic human bite bug. And finally, K is Kingella kingai, notorious for pediatric bone and joint infections. You might be wondering why group these specific bugs together in the first place. Well, it's because they share some very specific biological traits. They're all fastidious, slow-growing, gram-negative bacteria that actually require carbon dioxide to grow. But the absolute key here, they naturally colonize the human oral cavity. So if your exam prompt mentions a slow-growing, fastidious bug from the mouth, you should instantly be thinking HCAC. No hesitation. Section 2, the endocarditis patient. Let's shift our focus to the cardiovascular system, specifically HACK infective endocarditis. Now, Hacek bugs account for roughly 1 to 6% of all infective endocarditis cases. But here are your absolute must-know exam buzzwords. Look for a younger patient presenting with a subacute infection, meaning, it's been brewing for a little while. The only exception is Kingella, which is way more aggressive. The patient's history will almost always feature a recent dental procedure. Also, you've got to watch out for complications. These bugs cause a crazy high rate of embolic events. We're talking anywhere from 28 to 71%. And you're going to see vegetations on the echocardiogram in up to 85% of cases. That's huge. Now, board exams absolutely love testing distinguishing features, so let's get specific. When you're looking at the heart valves, you really need to contrast the mitral valve preference of Aggregatibacter and Haemophilus with the highly testable aortic valve preference of Cardiobacterium hominis. If that vignette highlights a subacute aortic valve endocarditis with long-standing symptoms, Cardiobacterium should literally jump right to the top of your differential. So, what about treatment? The crucial point across the board here is using ceftriaxone at 2 grams per day. You treat for 4 weeks if it's a native valve and 6 weeks for a prosthetic valve. But here's the massive, high-yield takeaway. Incredibly, even prosthetic valve endocarditis from Hacek is often cured with antibiotics alone, no surgery needed. That's a huge exception compared to other gram-negative prosthetic valve infections, making it prime testing material. Seriously, don't forget that one. Section 3, the bite wound patient. Let's step away from the heart, move into the trauma bay, and talk about bite wounds and zoonotic exposures. Okay, I want you to picture this classic clinical vignette. A patient walks into the ER with a severe, purulent infection right over their knuckles. The history reveals they were in a bar fight a few days ago, resulting in a fight bite, a clenched fist injury against someone else's teeth. What organism absolutely must you cover? The answer is Eikenella corrodens. Remember how we said this bug lives in the human oral flora? Well, that's exactly why it infects clenched fist injuries. Oh, and here's a sneaky secondary vignette they like to throw at you. Examiners love to associate Eikenella with IV drug users who lick their needles before injecting. They're basically introducing their own oral flora straight into their bloodstream. Now, treating Eikenella isn't exactly straightforward. This is a massive previous year question fact, so listen up. Eikenella has a very stubborn, specific resistance profile. It is intrinsically resistant to clindamycin, metronidazole, and aminoglycosides. If you guess clindamycin for this human bite wound, you are going to get the question wrong, period. Instead, you've got to reach for amoxicillin/clavulanic acid or ampicillin/sulbactam. All right, shifting gears from human bites to animal exposures. If the exam hands you a visual cue of a gram-negative coccobacillus with distinct bipolar staining, meaning the ends of the bacteria stain darker than the middle, kind of making it look like a safety pin, and the patient just had a cat or dog scratch, bam, you are dealing with Pastorella multicida, and penicillin is your absolute drug of choice here. Let's pull all this together and quickly contrast your bite exposures. Eikenella is your human bite bug, treated with amoxicillin/clavulanic acid. Pastorella is your classic cat scratch or bite, treated with penicillin. But you really need to pay special attention to the middle row here, the deadly triad of Capnocytophaga, Caniomorsus, dog bites, and asplenic patients. If a patient without a spleen gets a dog bite, Capnocytophaga can rapidly cause severe sepsis, disseminated intravascular coagulation, a purpuric rash, and terrifyingly fast gangrene. It's an absolute emergency. You must give prophylactic antibiotics to asplenic patients after a dog bite. Section 4. Pediatric and rare pathogens. Finally, let's explore how these fastidious organisms show up in specialized groups, starting with kids. When it comes to the K in Hacek, Kingiella kingae, here is a crucial stat you need in your back pocket. A staggering 80% of pediatric Kingiella infections are associated with a preceding upper respiratory tract infection and stomatitis. Think about that for a second. So picture a toddler, usually between 6 months and 4 years old, hanging out in a daycare setting. They've had a runny nose, maybe some mouth sores, and now they present with a limp. Kingiella is increasingly recognized as the absolute leading cause of pediatric septic arthritis and osteomyelitis in this specific age group. And it gets even trickier. Kingiella bacteremia can present with a petechial rash that perfectly mimics the terrifying presentation of Neisseria meningitidis sepsis. It's a real master of disguise. Now, because Kingiella is notoriously fastidious and incredibly difficult to grow on standard solid media, examiners frequently test this very specific high-yield culturing technique. To successfully isolate it, you must inoculate the drawn synovial fluid directly into an aerobic blood culture bottle. Doing this dramatically improves your recovery rate and gives you that definitive diagnosis. Okay, shifting gears completely to a rare tropical pathogen. The boards love a good color clue, don't they? If you're reading a prompt and you spot the phrase, violet pigmented colonies, isolated from a wound or blood culture, just stop reading. There is literally only one answer they're looking for. And that answer is Chromobacterium violaceum. This is an organism found in tropical and subtropical water and soil. While it's rare, it is absolutely devastating. It causes highly fatal sepsis with widespread metastatic abscesses. But the highest yield association here? It's with chronic granulomatous disease, or CGD. Patients with CGD have a defective neutrophil oxidative burst, which leaves them incredibly vulnerable to this specific bug. If you suspect this, you cannot mess around. Empirical treatment requires strong IV antibiotics, specifically carbapenems. And that wraps up our explainer. You've mastered the clinical vignettes from the clenched fist of Eikenella to the violet colonies of Chromobacterium. But let me leave you with this. When that exam clock is ticking down, will you remember which Hacek bug breaks the rules and cures a prosthetic valve without a surgeon's blade? Keep reviewing these structural clues, visualize those patient scenarios, memorize those resistance profiles, and you are going to absolutely crush your board exams. Thanks for tuning in.